from now. Camila is also wondering, see you later. Okay, I am not even part of that, no? Track 4. Yeah, track 4. To go Venus Day, no?
Hello, everyone. Can you hear me?
Yes. Yes, Jay. Long time no see.
Hello, Dr. Uma. Hello, Dr. Geeta. How are you?
Very good. How are you?
Let me increase the volume.
Can you hear me now?
I'm just waiting for the clocks to strike 4.
Okay, perfect.
Because I've been told to begin on time and end on time. Of course, ending is automatic. It it can cut us off, so they have automated the ending. But the beginning, I've been warned to start on time, so
sure.
I'm just holding on. I did see Dr. Ganesh Krishnan here a little while ago.
He's there now.
He came in, he popped in, and then he popped out.
Oh, he's there. I can see him.
Oh, I can't see him.
Yeah.
In fact, I can't see anybody except you.
Oh my goodness. I can see everybody.
Okay, got it. I can see everybody.
Yeah.
All right. Let's get this show on the road.
Yes.
Hello and welcome to the 58th edition of the Global Digital Annual Women's Economic Forum 2021. Let me restate that. The 58th edition of the Global Digital Annual Women's Economic Forum 2021. It's a mouthful, but I got it out of the way. Thank you, panelists, for joining us today. It's a wonderful cast of characters here we've got on the panel. I'm particularly enthused by today's topic, which is particularly appealing to me, navigating the changing healthcare landscape. And I say this for 2 reasons. One is, as an entrepreneur in healthcare, I'm navigating that healthcare landscape myself. Sometimes I wonder whether I'm making any progress at all. The second reason, and which is truly the reason I hopefully will enjoy this discussion today, I'm looking forward to it, is because 2 of the wonderful panelists we have here today are known to me. I've known them for many years, Dr. Geeta Arjun from Chennai and Dr. Ganesh Krishnan Iyer here in Bangalore. So 2 of them are known to me, and I've had the opportunity to discuss a lot of things relating to healthcare with them. So I look forward to having a wider range of discussions with all of you present and get to know each of you. Now, I've been told that I will be coming in once again 10 minutes before close. I should warn you that the close at 5 p.m. is automatic. I had no opportunity to stop that, so I'll be coming in 10 minutes prior to that, and I'm supposed to do the closing ceremonies. So at that point when I come in, I would hope that you're able to wrap up things, and then I would have 5 minutes to do my stuff and close the proceedings. So once again, welcome to all of you. And,
Jay, are you going to introduce all of us? Are you going to introduce all of us?
Yes. Thank you, Dr. Geeta Arjun. I'm not used to this, as you can see. So I'm learning on the by the seat of my pant here. Dr. Geeta Arjun is the moderator for today. She's the director and retired obstetrician and gynecologist at the E.V. Kalyani Medical Foundation in Chennai. Dr. Vijay Kumar was a general surgeon at Apollo Hospital. Dr. Evita Fernandez I understand she will not be joining us today
Had
because
some
of a personal
personal-
emergency.
Yes.
Dr. Uma Ram, Director and Consultant OBGYN, Sitapati Clinic and Hospital, welcome. Dr. Ganesh Iyer, Chief Cardiologist, Chief Cardiothoracic Surgeon at Aster Hospitals. Once again, welcome to all of you, and all of us look forward to a scintillating conversation here today. Thank you
for a wonderful introduction.
Thank you, Jay. Thank you for the introducing all of us. We have actually the group of us that are here today are all in the private sector of medicine as it's practiced in India. And I would like to start off with something that is the elephant in the room, basically. The fact that India has the most highly privatized healthcare system in the world. And this is for something, for a developing country, it is an issue, it is a problem. And therefore, healthcare sometimes seems to suffer. And quite often, as we go forward, we will have to remember this and try to work our way around it. If you think about it, the Indian government spends only about 3% of the GDP on healthcare, which is extremely low. If you compare it to other developing countries also, it is extremely low. Because there it can vary between 6 and 12%. Whereas, of course, the developed countries, it's as high as 16 to 18%. The issue is, how do we get away from this, and how do we navigate this healthcare system? How do we help? And we will come back to this at the end also. The first thing that we would like to talk about right in the beginning is, even in the private sector, there are smaller hospitals and there are corporate hospitals. So Uma, what is happening as far as small hospitals, and why is it becoming more and more difficult to provide healthcare, and what are the obstacles we are facing as far as small hospitals are concerned?
Thank you, Geeta. I think, as you said, if you look at private healthcare, there is, for a large percentage of India, which is the smaller towns, you don't have large corporate hospitals, and therefore private healthcare is being provided by small, typically 20, 25, 30 bedded hospitals, which provide private care. Now, I think, as is happening in many other businesses, these smaller hospitals are impacted for two or three reasons. One, because of the fact that it is increasingly difficult to get qualified nurses, and where we would manage with, say, ANMs, etc. Today, when you apply for accreditation, which is a very, very positive thing, and we should ensure quality standards, then we have to employ BSc nurses who are not very happy to work in smaller hospitals, and we may not have the paying capacity to match salaries that they get in the corporate hospitals. So manpower is an issue. Meeting these standards that are imposed even at entry level for some of these places can be a challenge, because it may include infrastructural changes which they are not able to cope with. Meeting the demands of the insurance sector, which we may come back to later, is also a challenge. And therefore, if we have to meet all these norms, then automatically the pricing goes up. And if the difference between a smaller hospital and a larger corporate is only about 15%, people will make that jump and either go to the corporate hospital or go towards public sector care. So I think this is the challenge, and where we would, which in some ways is unfortunate, because a lot of these smaller hospitals have been providing good care, and it's whether at all we are able to reinvent ourselves and how we do it is something that we need to wait and see.
Right, because one of the big issues and one of the big problems in India is that we have the highest rate of out-of-pocket spending. 62.6% of hospital bills are out-of-pocket payments and not through insurance. So that is an issue. Dr. Ganesh Iyer, when it comes to corporate hospitals, now you are in a highly specialized situation. How would it be possible for the, let's say, the common man to access somebody like you, or is it possible without out-of-pocket payment?
I am not very familiar with what's happening, but I think the corporate scenario is pretty much the same. And the way at least it works in my hospital is that out-of-pocket spending is about 30% of the patients. The remaining have some kind of an insurance cover. And we also do a lot of, I should not say a lot, maybe about 20-30% of my patients are covered by the Ayushman Bharat scheme. So they also, they don't pay a penny. So, I mean, so the out of spending is what I'm seeing is about 30%, not more than that.
Right.
But I'm sure the story is quite different in semi-urban or the rural setting, where, because from what I know, the insurance coverage of the population as far as health is concerned in India is probably in the range of 10 to 12%.
Yes, yes.
If that is correct, then 30% is an outlier.
Yes.
For what I'm seeing here.
Yes.
So the national average elsewhere will be 3-4%, which I'm assuming is the semi-urban or the not so urbanized pockets of the country.
Right.
So the focus of healthcare has to be in that level. How we are going to provide healthcare there. And cardiac disease is important, but because it's a killer. But I think people suffer other diseases more because they continue to live.
Right. So the thing is, the biggest change that has happened in the world, and I think it's impacted every country, every kind of small hospital, big hospital, corporate hospital across the world, has been obviously the pandemic, the COVID pandemic, which shut down the world for several times, and then has caused a pivot in the way we have approached healthcare. So when we come to that, every specialty had to provide management of patients based on COVID. Vijay, what happened to your practice? What happened to, you are a surgeon, and surgery, some of the elective surgery people were putting off. What actually happened to your practice when COVID hit?
I'm in a corporate setup. It's a fee for service. I'm not on salary. So it's badly affected from the first lockdown itself. And most of them, what I get is majority is elective surgeries. The elective surgeries completely shut down. So no elective surgery was done. And only few surgeries like emergencies and cancer surgeries, I did not say no. So I had to operate with a lot of fear. One surgery I remember still in June, I did mid-peak COVID, 8 hours laparoscopy, and it was 3 days I had a nightmare after that. So it's really mentally, we had a lot of agony and finances and what is a job? It was very difficult days we had.
Sure, definitely there has been an impact on doctors, on healthcare givers, because we had to continue to give healthcare without almost always worrying about ourselves. And therefore, there has been an impact on routine healthcare also. People who used to come in for routine checkups had to back off, and many cases which should have had early intervention were delayed. What happened as far as obstetrics was concerned, Uma, when COVID hit, and how did you navigate that path? Because deliveries are not going to stop. Women are going to continue to have babies. Nobody can say, oh, you know what, I will wait another 8 months and then come back when I've had my vaccine.
Yeah, I think as I said to many people, babies don't know about pandemics and they're already on the path to coming out. So I think obstetrics is one thing that did not stop. Of course, women were in a lot of stress because many places were not accepting COVID positive women. And so a lot of them, at least in the first bit, as soon as the pandemic started and the lockdown happened, and we were unsure of how to do the segregation, etc., many were referred to the public sector. So again, here is a situation where literally the public sector had to take in everything that was coming their way because certain parts of the private sector were not willing to, were not coping well, or were doing it at a price that the family could not afford. So I think for both these reasons, the public sector was overwhelmed. Personally speaking, we did accept COVID positive women who are already under our care from the beginning. We had the ability to do the segregation, and about, I think, 130 odd women we have delivered who are COVID positive. But that is not the situation everywhere. There was a lot of fear among the healthcare workers themselves, especially nurses in the first line. Families were calling them back. And, I remember some people saying, this is like, you're a soldier, and if you say at the war front, I won't fight and go back. But the thing is, nurses were not, and healthcare workers, we are not thinking of it as warfare, right? We're there, we want to take care, but internally there was a fear. The second time the lockdown happened, in the second wave, where actually women were affected far more badly, and we had a lot of morbidity and some mortality as well. I think it was amazing the way the healthcare workers recouped. They had vaccinated by then, and so there was a lot more confidence, and the care that was provided in most places was excellent, private or public. And I think that is something that, the rallying around, because the bottom line, everybody realized they had to do what they needed to do.
Right.
And yeah.
Right. So one more thing before we get off that topic, because this is something that everybody in the lay people all want to know. What is the effect of COVID on the mother? What is the effect of COVID on the baby? Because this is something, because people are going through, in fact, a lot of women called me and said, actually, I have nothing to do. There's lockdown. Both my husband and I are at home. Shall I go ahead and have a baby? And this was very early on in the pandemic, when we really didn't know what was going to be the effect of COVID on a pregnancy, on the baby, on the mother. So to give some sort of reassurance, what would you say at this point? Because COVID is here to stay. It's not going away. It's going to be here to stay. What would you say to women who are planning a pregnancy or already are pregnant?
First thing I would say is please vaccinate, because that is extremely important, and that can prevent problems. Pregnant women do get quite sick if they get COVID, contrary to what we believed in the beginning. And therefore, any protection and prevention is important, but the impact on the baby is small, and relatively the baby is protected. And one of the advantages of vaccination is that antibodies go to the baby. So I find a lot of reluctance in acceptance of the vaccine. So, and that would be my one most important message to them.
Right. So Ganesh, when because you are doing cardiothoracic surgery, and one of the important things that you do is CABG, right? You do bypass surgery for people who are having MI, heart attack. So there was a lot of reluctance. Did you not find that at the beginning, people, even when they did have the symptoms, they were very reluctant to come to a hospital, and therefore there was an increase in the number of people who had either fatal events or worsening of events?
Certainly that is true, because on an average, let's say my hospital sees 10 acute myocardial infarction admissions in the emergency room. And we do about 40 to 50 bypass operations a month. Now, I mean, and another 40 or 50 angioplasty stentings are done. So let's say 100 interventions out of the 300-400, maybe rest are thrombolyzed or they are non-specific trop negative events. But during the pandemic, the whole thing, at least the surgical numbers, dropped close to zero. Now, it is only speculation that one can do as to either they are dying at home, because the incidence of MI did not come down, yes, obviously, if it is the year-round average. So one would wonder whether they never came to the hospital, because of the fear of the pandemic, and probably some of them died at home. But incidentally, when the first lockdown opened, we saw a lot of people with regional wall motion abnormalities. That means they have had MIs, lived it through, and then have presented with these kind of LV dysfunction. So it's kind of strange, but the numbers were definitely down. It's only speculation that many of them would have probably died at home following a fatal event. But obviously, there is no way we can get credible data on this, because the autopsy rates in our country is so poor that one can never actually find out why a person died.
That's right. That's right. So Vijay, the thing is, things like acute appendicitis, situations like bowel obstruction. These are people who actually have a severe emergency, but they were staying back because they were too nervous about coming to the hospital. Did you find that you were having, if at all you dealt with a situation, a surgical, an emergency, it was much more advanced, much more complex than it would have been in the normal times?
After me vaccination, I was not worried to operate any emergencies. But in 2020, during peak, I had 2 emergencies. The appendicitis generally, otherwise also, generally I don't operate appendicitis. I try to manage, with the medication, and if it is not very serious.
Right.
So the appendicitis I could manage. Later on, I operated on them as an interval appendicectomy. And the other one, bowel obstruction, I could not manage in my setup. So I had to refer the patient to the bigger setup, the Grimsrud Apollo.
Yeah. But you did find that people were postponing just because of the fear of coming to the hospital.
Yes, exactly.
And they were presenting with more complex situations.
Presenting with more complications and more troubles.
Right. Now, so because of this kind of situation where both doctors were a little reluctant to take care of patients, because again, there was, before I say reluctant, I would say that the majority of doctors went out of the way. And I think the whole country, the whole nation owes a debt of gratitude to doctors who went out of their way, took their lives in their hands, and continue to provide healthcare across the country. And I think that is something that the public must remember for a very, very long time, because every day, children, what we call children, but youngsters, interns, postgraduates, they were going to the hospital every day. Young nurses with children left at home, not being able to go back home because they were worried that they would infect the children, because there was not much information at all in the beginning. They went ahead, and truly, we have not, as doctors, we have not taken an oath to give up our lives. Like, they keep comparing us to the army or the warriors. We are not warriors. We are definitely out there to save lives. We will do everything to save lives, but never has in any situation in the world or in all these hundreds of years of healthcare being available, organized healthcare being available, have we ever said that, we will give up our lives fighting for a patient? All right. But so this did put us in a very strange situation, and I think we did cope up with it. But because of COVID, I think there has been a pivot. We have suddenly discovered new ways of handling healthcare, of providing healthcare. And in that, I think telemedicine and teleconsultation has had a very big role to play. Uma, what has your experience been with teleconsultation? And I'll come to each of you. I want to know what your experience with it is as far as patient acceptance, because the person who is going to receive it are, as far as I know, Indian patients love to come and see you face to face. They want to have a conversation with you. So how did they accept this? So first of all, how did you set up a telemedicine? How did you pivot to that? How did you go in for teleconsultation? Uma, would you like to start?
Yeah, sure. So I think initially while we were trying to put systems in place, it was a lot of calling and talking on the phone, especially because with obstetrics, there was a lot to reschedule. I mean, there were ultrasounds to be done. And I think one of the things we learned is probably we don't need to do as many scans as we were doing, because the low risk women really, we were, because people who were scanning could not scan as often. So those were changes. But with the context of telemedicine, I think initially it was phone calls. But then quickly we got on to, because we already had an app for the patients to reach us, we got on to a video consulting platform and were scheduling, and we found that quite useful to communicate. However, I must say that it is very convenient for a population which is comfortable with the use of a smartphone or a video conferencing app. There is a large percentage of patients, even in a city like Chennai, where we basically cater to a middle class and an upper middle class population, where women particularly are not that savvy with, they could do a WhatsApp call maybe, but if you give them a platform to log into, they struggle. Interestingly, many register with their husband's mobile number. So many times when we called, we had a male voice saying, I'm not with my wife, but I can tell you what problem she has. And we had to say, no, but we want to talk to her and not to you. So this was a very interesting thing that happened. And so we have started asking, please give us your contact number so that we can register you in the hospital with that. So, but I think the video conferencing has made it very easy, especially for reports. For simple follow-ups where people don't have to come and wait 1 hour, 1.5 hours just to be told this is what you do, out of city appointments. So these things, I think it's come to stay. Personally, I'm very happy that this is a way in which we can reach people and people can reach us.
Right. So Ganesh, have you found that teleconsultations are going to become part of your going forward? Will it be part of the healthcare that you're going to be delivering? As Uma said, for reports, because a lot of times they come and sit for 1.5 hours just to show you one report, and then maybe you're going to schedule them for surgery or something. Do you think going forward you're going to use teleconsultation much more often?
Yes, I do think that's the short answer to your question. But the longer answer would be that it has been going on for some time, even before the pandemic. Because there are people from outstation, say faraway towns like Hubli, Gulbarga, West Bengal, southern Maharashtra, Western Maharashtra, they come to Bangalore and they have been emailing reports,
right,
and WhatsApping reports, doc, what's your opinion and should we come down? So the initial consultation used to take place on those. Many of them used to make a call. But the advent of the pandemic has given birth to the video consultation platform. So my hospital has actually, I think, invested on a software where their patients themselves can schedule an appointment. And being a corporate, they have figured out a way to charge as well for that.
Exactly. Yeah, that's one thing I wanted to ask, because obviously, because you can't do teleconsultations without having this concept of actually being paid for it, right? So there has to be a platform for that. Yes.
They have created a platform where they pay upfront and then schedule. The moment the appointment is scheduled, I get a WhatsApp, not WhatsApp, there's a hospital notification system where I get notified that on such and such a day, XYZ has done this. And it also tells me if he has uploaded any reports for review, or anything that I need to see before I start the consultation. So, and it will remind me 5 minutes before the time is there. So there'll be a beep that goes on my phone. So then I know, okay, I have to stop whatever I'm doing and get ready for this teleconsultation. If I'm busy doing something, I tell my secretary to call them and say, reschedule it for 1 hour later or whatever it is. Sure. So that platform works very well.
Right.
And that is now post-pandemic being used by almost 50 to 60% of the post-op follow-up patients.
Correct. Correct.
Post-op follow-up, because they do a routine blood, they upload the results, I check everything, maybe change the aspirin dose or a clopidogrel dose or a statin dose, it doesn't make a big difference, and they don't have to come here and wait for. In fact, many times I am waiting for them on the video consultancy.
True. Yeah. So I think this is one of the major changes. My very good friend, Dr. K. Ganapathy, who's really the father of telemedicine in this country, he has been touting this telemedicine for years and years and years. And now suddenly COVID made us all the naysayers or the ones who scoffed at it, saying, oh, we need the personal touch. We have realized that this may be one way of making it easier for the person, easier for the doctor, and also reducing the waiting time. Large numbers of hours spent in a doctor's waiting room. Now, when it comes to surgery, Vijay, I know that you have to put your hand on the patient to really say that there is a problem or not. But they talk about actually video conferencing and having the patient put their hand on wherever it hurts, getting some sort of an idea, and then proceeding and saying, oh, okay, you need to come in, or you know what, this is just a small abscess, it's not a hernia, I will give you medication and I will treat you. Do you think a surgical practice will do okay with teleconsultation?
It's very difficult. It's very difficult. Sorry, sir. You wanted to say something.
No, Ganesh is not. You go ahead.
Okay. Yes, it is very difficult without touching the patient. Being a surgeon, I don't know. Still, I am finding it is difficult. But post-operative patients, yes, I am able to manage with the consultation, and Apollo has developed a wonderful platform for it. It's not an issue. It is very seaming, and we don't have any problem.
Mm-hmm.
I wanted to add one positive point, what Dr. Uma said here. When you are calling, the husband is answering. Indirectly, you are involving the husband also in the maternity care. That's a positive thing here.
True. No, that is true. But I said that in the context of it was eye-opening actually to know that many times, even if the woman has a mobile number, when they register, they don't give that as the registration number. For the life of me, I don't understand why, but that's how it is. So we actually have a postnatal messaging service as well, where we send out a message for the first 100 days after a postnatal, after a woman delivers, so that every day there's a message that goes, assuming they sign up. Now they sign up for that also with their husband's numbers. So, and traditionally in India, you know that the woman goes back to her mother's house. So it's not like she's at the same home as the husband who can just show her the phone and say, see, read this message. So for these reasons, it surprises me that this happened. So that's
COVID made this.
No, but again, Vijay, you must remember that Uma and I come from a very long history of a hospital which has involved husbands in the delivery process a long time ago. I have never said that a woman got pregnant. I always say they got pregnant, okay? And we've had husbands in the labor room in our hospitals from 1982. So it's probably one of the only hospitals now it's becoming more common, but from 1982, we've had husbands in the labor room helping the mother. So we believe that husbands have to be involved. In fact, we drag them, and we don't see women unless the husband is with them. We don't see them with their aunts or their mother-in-laws or their grandmothers. We first say, if the husband is available, he has to be there. So we always involve the husbands. Yeah, right. So, yeah. So the other thing is, again, to quote Dr. Ganapathy, he said that now the teleconsultation, this is a thought which I thought was really, really important. Now that teleconsultation is here to stay, we have to move a little bit from the bedside manner to the website manner, where we actually have to schedule these things as professionally as possible. We can't do it with, the kids running around, or, in a place where they feel that you're not paying them enough attention. You have to be focused on them, just as you would be in your consultation room. You have to set it up in such a way that it is still very, very professional. They don't feel that they're talking to you while you're having a cup of tea at home, or the TV is blaring at the back, in the background. So you have to, this I think is something, as we go forward and teleconsultations become more and more common. And as far as, you said it's only in the urban areas, but I do find, having traveled in a lot of semi-urban and rural areas, that people carry smartphones. People are so tech savvy, even if the woman is not, the husband, the son, the brother, somebody is there to help them through. So we will be able to provide teleconsultations for a long time to come, is what I believe. Do you believe that this will become mainstream? This is one question. Or are we going to, maybe 4 years down the line, getting back to the same sitting in the doctor's waiting room? Do you think this will become mainstream? Do you, as doctors, feel that this is what you want to do? Digital healthcare. Yes, Ganesh.
Yeah, so I think that as far as post-operative care is concerned, definitely it can be made into a mainstream approach, especially if the patients you on a teleconsultation find that they are completely asymptomatic, they are doing their exercises, complying with whatever. But if there's any doubt on a teleconsultation, you can ask them to come and say, you should come and meet me, or get a TMT done, I want to review it, or I want to review an echo. But pre-operative, at any stage, pre-operative counseling maybe a little bit can happen, but I would not operate on a patient whom I have seen on a TV screen or a monitor. So I have to see him, examine him, get the feel for his, because
I agree with that completely. Hands-on.
Chronological age, and there is a biological age. Every 70-year-old is not the same. So for that reason, I like to talk and then get a feel for the family as well. So that's where I think the patient doctor bonding kind of takes place, as to how you talk, how you sit, and how you manage them as human beings, not as patients.
Exactly.
So that's where that initial, once they have that, then sitting behind the TV screen and talking to them, they have the same emotion. But unless you have built that, I don't think you can have the same emotion that develop to a person who's sitting across.
Face to face. I absolutely agree. So Vijay, you will not operate obviously unless you have actually touched the patient.
Obviously, I don't do it. Two things are here. I have a fear that I may go wrong.
Yes.
Personally, I involve, the physical examination more than the investigations. I still, appendicitis, polycystitis, hernia, all these things, I go for clinical examination. Only when patient needed, I ask for a radiological examination and investigation, and of course, taking prior to the surgery. And the second thing is, legally, are we able to manage these things?
Yes, very true. I definitely believe in laying on of the hands. There is no question. It is not only for yourself to make the diagnosis, everything. It is always the touch between you and the patient is so important. They feel very soothed. They feel calmed. They feel that you have actually helped them, held their hands literally. And that I think is important. But as we are seeing, the number of times that we have actual face-to-face consultation may come down, and this might become more mainstream. And I think this might also be easier. What do you think, Uma, if you can have them have a separate clinic just for teleconsultations, and it doesn't have to be, like just maybe an hour or 2 hours every day, and then they can come in if you feel that it's important. Have you started doing that already, or?
I mean, yes, a set time, few days of the week. It could be 1 hour a day, depending on what the uptake is, an individual can segregate. Personally, I have now 3 days a week where there are 1.5 hour slots. But then once the slots are open, patients can book themselves as well. Yeah, for gynae, it works very well for just as what both Dr. Ganesh and Dr. Vijay said. For obstetrics, I think it works well in the low risk woman who is, in between. You don't necessarily need to see them. High risk women, I think without a doubt, they need to come in because you can't judge many things by seeing them. And as was true in the pandemic, a lot of women with severe hypertension, severe preeclampsia, ran into a lot of trouble because they were scared. They were the ones who needed to access healthcare and they stayed away. And I think that those high-risk women we need to see, which actually may be a good thing because your clinic is not so busy as it used to be anymore. I think we used to, sometimes really pack our clinics. Now we've been forced to give those longer time slots. So I think it has translated into focus on the more high-risk woman when she walks in. And this is from the point of view of an obstetric clinic, I'm saying. So yes, it has its advantages in that sense. Right.
So I want to add here, Dr. Ganapathy, I know personally also, who does telemedicine consultation. There it is different, completely different. There they pull the patients in a different place, like suppose West Bengal or Assam. They pull the patient and doctor examines and they give the reports to the particular consultant. In that way, maybe it works.
Yes, I understand. But that's the thing is, because that's how it started, that remote areas were being accessed with help from doctors in the urban areas. But now it suddenly has exploded. People are bringing it into daily management, daily consultations, much more. I don't think any of us would have thought about talking to a person just on a Zoom call before the pandemic. True. Certainly would not have, right? Okay. So I want to just move on to what is the positive impact that COVID has had as far as healthcare delivery is concerned, and which will, I think, resonate through the next several years. And because there has been a lot of public health awareness. And I think the biggest public health awareness is that infection can be prevented. Now, you ask any child, they know that you have to wear masks, you have to wash hands, you have to keep your social distance. And we know that the number of cases of asthma, the number of cases of seasonal flu have all come down. The number of children who used to come in with the common cold to the emergency room in pediatric hospitals has dropped. The number of children who used to come in with severe asthma has come down only because of these preventive healthcare measures, including infection prevention. Now, the understanding when we get a new infection like COVID, I think the one thing that we learned from the huge absolute panic at that time is that everybody jumped into any treatment or therapy which people thought might work for COVID. And at the end of it, we have realized that however new the situation is, we cannot panic and we cannot start using medication without evidence. The number of antibiotics that, we know that even ivermectin was being touted. A lot of medications were being touted as the treatment. And I think, what do you think as far as what has the impact been on managing new situations? Has it not brought out that we have to be extremely evidence-based? Ganesh, would you like to comment on that?
Certainly. I think you're entirely right in that, I used to joke around with my patients saying that, India has got 130 doctors, because you go and ask, you say, I have stomach pain. Everybody in the house has got some treatment. tulsi water, this, that, and all. So evidence-based medicine is the way to go. There's no doubt about it. But somehow in our country, people are reluctant when you suggest them that this is evidence-based, because they'll say they will still go and try Ayurveda. I'm having hundreds of patients who require a bypass or a stenting, but they'll say we'll go and try chelation therapy, or we'll go and try this. Because the intervention, see, as long as it's popping a pill, I think it's okay. But when you say I'm going to intervene, I'm going to cut you open and then do this and do that, I can understand the reluctance on many part of it. But one thing, as you rightly pointed out, is that we have to look for evidence and find that evidence and then say, okay, we are having evidence about this. When patient asked me about chelation therapy, I said, look, I don't know anything about it. Do you want to try it? You please go ahead and try it. And if I have a MI during the trial of chelation therapy, that's your fate. I can't help you with that. So evidence-based is one thing, but as you rightly pointed out, I think the major positive of this is the telemedicine. I think the way people are accepting it, both as physicians accepting it and patients accepting it, I think that is the real big positive.
Right. Right. When I talk about evidence-based medicine, I'm talking about allopathic doctors practicing what they should be doing, evidence-based. What patients believe and do, we cannot always control, because we know that there was some sort of kudinir, something which was being touted.
So Geeta, I think the issue with during the pandemic was that traditionally, when there's evidence generated, when a drug is being tried, when a vaccine is being tested, it comes over time in a journal which doctors read, and then we try and figure out. I think what happened in the pandemic is, as this scientific evidence was being generated, parallelly in the press and in the WhatsApp University, all of this same information was being sent around. And therefore, this understanding, the nuanced understanding of what is evidence-based medicine is something that is challenging for many doctors. Yes. So you have a preprint of a journal that are based on some 50 cases on something that is WhatsApped into a family group, and people read it and they say, okay, this is the panacea for COVID. There is no way we can control that. And I think that has been a challenge. I don't know what the others feel about it. And I think that's why everybody had an opinion. Anybody who was not an epidemiologist had an opinion on how these waves were going to come and go. So I think the positive is a lot of science got focused. That's how we got the vaccine so quickly. There was a lot of support. Those are the positives. But the way that information was spread, because of the same social media means that allows us to interact on telemedicine, etc. Similar social media means that spread this message to everybody, including the people who are going to use it. So even if you said you don't need remdesivir, they were willing to go stand in line and get it.
Yes.
So that was a challenge that I think the pandemic enforced on us.
Because everybody got their PhD from the University of WhatsApp. No question about it. Whether it was doctors or whether it was lay people, everybody was extraordinarily informed. Everybody had a strong opinion. But what the lesson ultimately we have learned is, of course, in this situation, we had to go with every treatment that came in because we were trying to save lives. But the bottom line is, we have to at one point say, okay, this works, this works, this works. There's enough evidence for this. And now we are going to set up a protocol for every COVID pregnant woman who comes into the hospital, every COVID positive person who requires surgery. So we have to have those protocols and processes in place as far as the present time is concerned. Whatever evidence we have to incorporate that into our practice.
And one of the things I think, and Dr. Ganesh could also add, and Vijay, that I think we saw the government coming together, bringing in people from the public sector and private sector to try and set these protocols up so that there was some kind of standardized care. I don't think we've seen it happen in this fashion for any other kind of disease.
Yes.
And that hopefully that is something that will continue, and this public-private kind of bonding or partnership should increase, because ultimately that can be a huge positive spin-off from the pandemic for healthcare in general.
Exactly, because there is no question about it. One of the negative things that came out of the pandemic was the huge inequity of delivery of healthcare. Whether if you had money, you had different kind of treatment. If you didn't have money, you had a different kind of treatment. But certain governments, and certainly the government of Tamil Nadu stepped up like anything. And I've known a lot of other governments also stepped up and put in place a lot of care for people. And it was not based on how much you could pay. And I think, as you said, that kind of stepping up for healthcare is where we need to go, because that is where we will get away from this out-of-pocket paying, privatized medical care. We do need to have the government helping out in a much, much greater fashion. And we are almost, we've got some more time before Jay will step in. So one of the things that became a meme in social media was doctors were being accused of profiteering. Companies were accused of being profiteering from COVID. Do you think this is justified, Vijay? Do you think this is justified?
No, I don't think so. Maybe one or two black sheeps might be there, but actually not the doctors and nurses doing. The other people who are, who does not have emotions. Actually, doctors and nurses always have emotions to the patient. Then only we can treat.
Right.
This is there from the joining of MBBS. We have learned this and we practice this. So the people who does not have this, for example, the oxygen supply, remdesivir supply, even to get the bed. I know people who are roaming around the hospitals. If they don't have a bed, I tried helping many people, many patients to get the bed and oxygen. I know these people are making profit out of it, sending the patients from hospital to hospital who does not have any connection with the hospital or healthcare system.
Right.
So there are middle management people who made it, and we got the bad name out of it.
Right, exactly. Because the cost of healthcare delivery did go up, no question about it. Because all of a sudden, the half the hospital or 1/3 of the hospital was now being taken over by COVID patients. The other income for the hospital did not come in. What did you find, Ganesh, when in your hospital? How did that affect?
Yeah, as you rightly said, the public perception was that, the hospitals are profiteering, but the reality of the matter was, as you rightly mentioned, that the costs had gone up because we were wearing regular masks for surgery and walking around the hospital. Now everybody needed an N95 mask to walk around. That itself cost 250, 300 rupees. So I think the cost had gone up. A lot of nurses suddenly left, and they went back to their homes because their parents called them back. Their staff was under pressure. The PPE kits were not available. So I think profiteering has happened, but in the non-medical field, in the sense, people manufacturing PPEs or these N95 masks, because today we can buy an N95 mask for 35, 40 rupees. But at the peak of the pandemic, we all paid 300 rupees to buy those masks.
Right.
So you know that, I know that. But so that is where the profiteering has happened. But I don't know any medical profession, either a doctor or a nurse.
Exactly.
Profiteered as that way. But yeah, because of increase, like a pulmonologist, he used to see 20 patients a day. Suddenly he's saying 40, 50, 60.
Right.
Obviously, his fees increase, so his income might have gone up, but he has done equivalent work for that. He's not been sitting around and getting the money.
Right. And not only that, he's been putting his life on the line every day.
Exactly.
Because when you're seeing COVID patients every day and you're worried about going home, you might be infecting your wife, your children, your husband, all these things come in. So as you said, this is a public perception, which I wanted to
How many doctors and nurses lost their lives?
Yes, exactly. So to just wind up, when we think about what is the future, what this whole discussion that we had to navigate the healthcare. The two things that I think have come out very clearly is that third-party coverage has to become universal. That is, we have to work with the government to make sure that we don't continue to have this kind of out-of-pocket payment. And this has to be a policy decision which has to be taken up at the highest levels, because India can't afford to keep on doing this. People can't afford to keep paying out of pocket. And I think that is something we have to really, really talk about. And then again, how governments, in the Indian government has to increase its spending of the percentage of GDP that is spent on healthcare. Healthcare has to go as high up as education when it comes to socialized medicine in this country. What are your opinions? Can we have your final opinions on this?
I think you're entirely right. And there are, I think the government has to set up some kind of a body or a think tank as to how this can be achieved. I'm sure there'll be divergent thoughts on, how this can be achieved, whether a percentage of the GDP has to be paid to some insurer to insure the whole population, or they are going to, come up with mechanisms. But I think this certainly will not happen overnight, but I think at least the constitution of a think tank to achieve this over the next few years would be an immediate thing to do, I would think.
Yes, yes. Uma, you wanted to say something?
Yeah, no, I just wanted to say that yes, insurance and third-party coverage is important. People should have it, whether it comes from a private insurance or the government. But there needs to be some buy-in from the doctors to help guide what should be the standards, what should be the rates. Because at one level, even for a simple hysteroscopy, they want an overnight admission, which is completely, daycare procedures, you don't need overnight admission. And at the same time, for some very complex procedures, the fee that they allow is so small that, it has to be meaningful both ways. So I think there needs to be some cohesive guiding or discussions to navigate this. Otherwise, we'll end up like in a situation like in America, where, even if you're having a severe sepsis, if you don't have the coverage after 48 to 72 hours, they tell you go home. No, we don't want to end there. So there has to be a conversation which is meaningful to ensure that we take this third-party coverage and insurance in the right direction. And the government schemes also end up paying the hospitals. Otherwise, after a point, they can't do a CABG for nothing also. So I think both of those things have to be taken into consideration.
Right. Absolutely. Everybody who is involved in this, including the insurance companies, have to have a policy which is agreeable to everybody, the consumer, the doctors, and the companies themselves. Jay, I can see you're back. We are done.
Thank you, doctors. A very informative and enjoyable conversation. I can tell you, I've been moderating, or I should say, track moderating several of these today. And this is the only one that I've sat right from the beginning to the end. There's, of course, a personal stake here, and I truly enjoyed it. I wish I could ask questions. Unfortunately, this is not the forum. I had several questions about proximate care versus remote care, acute care versus chronic care, things of that sort. And unfortunately, that we'll have to hold off for a future date. Something that Dr. Geeta Arjun brought earlier in this conversation, I would like to recall that, and that is the sense of gratitude that I think society today owes to the healthcare community at large. If the pandemic has shown anything at all, it is just that how much of this really owes to the great work by all of you. So on behalf of everybody, every citizen in India, I wish to thank all of you for all that. that you have done for all of us. And congratulations on that. Now, I am called upon to finish this thing with one last thing, and that is on behalf of the Women's Economic Forum 2021, I would like to confer the Leader of the Decade Award to Dr. Geeta Arjun, the Leader of the Decade Award to Dr. Vijay Kumar, the Leader of the Decade Award to Dr. Evita Fernandez, Leader of the Decade Award to Dr. Uma Ram, and last but not the least, the Leader of the Decade Award to Dr. Ganesh Krishnan Iyer. Once again, thank you so much for spending so much of your time. I know time is extremely valuable to all of you doctors. I've seen Dr. Ganesh Krishnan Iyer in the hospital, and he hardly has a moment to breathe. So I fully understand that. So for you to spend so much time, 1 hour here with us, is an amazing act of public service. So thank you very much. And we look forward to having another such conversation sometime in the future that addresses some of those questions that I have that I would like to discuss with each of you. Thank you very much.
Thank you.
Bye-bye.
It's
And
been
you have a
honor.
safe year ahead. Bye-bye.
Thank you so
Thank you.
much.
Bye.
An honor and a privilege. Thank you so much.
Bye-bye.
Bye.